Hello, my name is Helen Wren. For my presentation today, I will be discussing Parkinson's disease. In this presentation, I hope to provide an overview of the disease through discussion of the structures and functions of the brain it affects, the symptoms that typically manifest, how it is assessed and treated, and the role of a speech-language pathologist in the treatment of Parkinson's. It should be noted that Parkinson's disease can be simply abbreviated as PD. Parkinson's disease is a neurodegenerative disease that has a slow, progressive onset and causes identifiable motor symptoms such as hypokinesia, bradykinesia, muscle rigidity, and asymmetrical resting tremor that can affect everything from a person's gait to their ability to speak. Parkinson's disease is a prevalent disease that affects hundreds of thousands of people all over the world. It is stated to be the second most common neurodegenerative disease worldwide, and an estimated 60,000 Americans are diagnosed with PD each year. Due to its prevalence and wide-reaching effects, a basic understanding of the pathology and effects of Parkinson's disease is essential for any clinician. Parkinson's disease most commonly results from the regressive changes in the pars compacta region of the substantia nigra of the midbrain, which results in a lack of cells that produce the neurotransmitter dopamine. This lack of dopamine being generated in the pars compacta leads to a subsequent lack of dopamine in the striatum and caudate nucleus as well. It is important to note that the substantia nigra is considered to be part of the basal ganglia, which is a system responsible for modulation of motor movements, muscle tone, and planning of movements due to its connection to other brainstem nuclei. Dopamine is a neurotransmitter that allows the substantia nigra to communicate with other areas of the brain in order to properly plan smooth and efficient movement. Therefore, a loss of dopamine greatly impacts the basal ganglia's abilities to regulate and control movement. People with PD also commonly show a loss in the neurotransmitter that's related to dopamine and is the primary messenger of the sympathetic nervous system, called norepinephrine. This can lead to many issues in the body's regulation of digestion, heart rate, blood pressure, and so on. No one cause has been linked to PD, as patients with PD make up a heterogeneous group. Some research suggests that Parkinson's disease can be linked to environmental toxins, genetic mutations, protein buildups in the brain called Lewy bodies, and even dysfunctional mitochondria. Bradykinesia is a common symptom of PD and is in most cases synonymous with hypokinesia or slowed movements. Brain imaging studies seem to suggest that bradykinesia in PD patients results from impaired communication between the striatum and critical cortical areas for motor control, such as the primary motor cortex, premotor cortex, and the supplementary motor cortex. These areas are critical for the planning and initiation of motor commands, so disruption in the communication results in impaired movements. As previously discussed, this dysfunction in communication or connectivity seems to be linked with dopamine levels in the brain. Similarly, the tremors commonly seen in PD may be associated with the lack of connectivity between the basal ganglia and the cerebellothalamic circuit, which is important for the fine-tuning and smoothing of motor sequences. Non-motor issues related to memory, emotion, olfaction, and cognitive function can also be present with PD. This again may be linked to cortical communication that's disrupted due to a lack of dopamine. It should also be noted that depression is very common in patients with PD. Many different types of dysarthria, which is defined by the Mayo Clinic as a speech production disorder caused by oral motor weakness, paralysis, or incoordination, as well as dysphagia, which is a swallowing disorder, voice disorders, and difficulties related to the comprehension and use of speech as language due to cognitive impairment, are all commonly seen in patients with PD. Some PD patients even exhibit acquired stuttering as the disease progresses. While the exact neuropathologies behind the link between these disorders to PD are not completely understood, the deterioration of dopaminergic cells in the brain seem to be linked to the cognitive and motor dysfunction related to these disorders. Here are two graphics showing the non-motor and motor symptoms typically associated with Parkinson's. On the left are the non-motor symptoms, and on the right are the motor symptoms. Diagnosis of PD is usually a long and tedious task. It is based upon thorough clinical observation and differential diagnosis, and it can typically take up to a year to diagnose. According to Al-Sharif's summary of the UK Parkinson's Disease Society Brain Bank position, for a person to be diagnosed with PD, they must first meet certain criteria to identify them as having Parkinsonism. Parkinsonism is when a person has Parkinson's-like symptoms, but the symptoms are not necessarily caused by Parkinson's disease. They can instead be caused by drug use, carbon monoxide poisoning, and more. These symptoms include those discussed previously, such as bradykinesia, postural instability, muscle rigidity, and more. There is also exclusionary criteria such as an etiology that would not be associated with PD, like a history of repeated brain injury, early severe autonomic responses, lack of response to PD medications, and so on, because these issues would likely point to something other than Parkinson's disease. While there is no cure for Parkinson's disease, there are a wide range of treatments available. Typical treatments usually involve pharmacological therapies aimed at reducing the motor symptoms present in PD. These include different neurotransmitter modulators, such as anticholinergics, MAO-B inhibitors, dopamine agonists, and levodopa, most of which have an effect on how the brain synthesizes dopamine. Levodopa is one of the most commonly used drugs to treat Parkinson's and is usually administered in tandem with an enhancer called carbidopa. Levodopa is a dopamine precursor, meaning it promotes the production of dopamine in the brain, which can help alleviate some of the symptoms typically seen with PD. It is important to note, however, that long-term use of levodopa and many other PD medications results in a loss of effectiveness over time, so careful management of pharmacological therapies is necessary. Non-motor symptoms such as depression, hallucinations, high blood pressure, and digestive issues are also typically treated with drug therapies, using medications such as tricyclic antidepressants and SSRIs. Surgical solutions such as the implementation of a deep brain stimulator in parts of the basal ganglia such as the subthalamus have also been found to alleviate both motor and non-motor symptoms of PD. An interesting role that deep brain stimulation can play is in the alleviation of acquired stuttering for some patients with PD when a deep brain stimulator is placed in the left subthalamic area of the brain. Because Parkinson's disease affects such a wide range of functions in the body, diagnosis and treatment will involve a team of specialists including neurologists, physical therapists, speech-language pathologists, nutritionists, and more. As previously discussed, Parkinson's disease can affect a wide range of functions that may fall under the scope of practice for a speech-language pathologist. According to ASHA's 2007 Scope of Practice Statement, an SLP can be responsible for the diagnosis and treatment of a variety of speech, language, communication, and swallowing disorders ranging from stuttering to dysphagia, and that one of the possible etiologies of these disorders may be Parkinson's disease. An SLP's role can include referral, screening, diagnosis, treatment, documentation, and collaboration with other healthcare professionals. An SLP's treatment of a person with Parkinson's will usually come after the diagnosis and progression of the disease, as it begins to take effect on their ability to communicate and/or swallow. For example, an SLP may conduct a video fluoroscopy to assess a patient's swallowing abilities and then perform therapy from there to best improve their swallowing. Additionally, voice therapy can be conducted to improve resonance. For example, the Lee Silverman voice treatment therapy has been effective in treating dysarthria, palalia, and hyponasality in patients with PD. So in conclusion, Parkinson's disease is a highly prevalent neurodegenerative disease that affects a wide range of body functions due to a lack of dopamine in the brain. While there is no cure for PD, many different medications, surgeries, and therapies can help alleviate some of the symptoms of the disease as it progresses. Due to its prevalence, it is important that speech-language pathologists have an understanding of PD, as they might be responsible for treating a patient with PD in order to help their declined swallowing, speech, voice, or communication abilities. Thank you so much for watching. Here are some of my references, and I look forward to your feedback.